just as everybody is aware, we're recording it as well. So if you've got any questions, the session will be in 3 sections. During the first session, you will have an opportunity to ask questions. You can put it in the chat box as well, and I can collate that and share that with Mark, and we'll be able to answer any question. I hope you find today's session very useful. And if you have any questions, please feel free to ask during the question and answer session. Thank you very much, Mark, and over to you, please.
Thank you very much, Bola. And I just want to welcome you to this presentation. And thank you very much for your time. I know everyone is very hard pressed and has 1 or 2 things on their plate at the moment. So I'm Mark Newman. I'm the head of audiology here at Barking Havering and Redbridge. We're over Queen's and King George Hospital. And today I'd just like to talk to you through a few bits and pieces on audiology. We will be, as Bola mentioned, just in 3 sections here with adequate time for questions and answers as we go along. And just to say the usual thing, we're pleased with the microphones off, and Bola will take some questions, and we'll have a little bit of a break. And we had a little bit of problem with the share earlier, so Bola might read out the questions and I'll answer them to the best of my ability. So first of all, let's just go through the agenda on what we'd like to do today. Just want to go through who we are, what we do, and how we do it. Some audiology test results and interpretation, which was raised as something that people would be interested in seeing. We've got a few case studies, a little bit on accessibility, and then what next we're doing for the department. So what is audiology? So first and foremost, we're healthcare scientists. We're concerned with the diagnosis, treatment, and rehabilitation of patients with hearing imbalance disorders. So in terms of referrals, we accept referrals directly from the GP, and we also do tests for the ear, nose, and throat patients of this hospital. And we accept also patients from neurology and further afield. We also do advanced diagnostics. We help people with their tinnitus and remove obstructive earwax. Should just mention that we're kind of an adult audiology department. I think a few things came up on about pediatrics, and I'll do my best to go over them as well. But just to say, first and foremost, we're adult audiology here. So going into a little bit more depth now, we can handle the direct referrals, which is your direct access and through your ERS systems. With the ENT clinics, we're doing the hearing tests, tympanometry and reflexes, and our advanced diagnostic include things such as speech testing, OEEs, and balance assessment. In terms of rehabilitation, we fit hearing aids, latest digital hearing aids. We help people with the tinnitus management, and we take wax out of audiology patients who have obstructive wax, and it's preventing them from either being assessed or using their hearing aids effectively. And this is why we do it. So currently at the moment, there's around 12 million people in the UK with a hearing impairment, and that actually equates to around 1 in 6 of the adult population. So that means if you see how many people are on this seminar at the moment, 1 in 6 of us will be suffering with some form of hearing impairment. That equates to about 900,000 people in the UK who are severely or profoundly deaf. And interestingly, only about 2 out of 6.7 million people who are eligible for hearing aids use them. And we'll be going into that a little bit more depth in a bit. So ideally, we need to get everyone hearing as well as we can. Global burden of disease looked into the hearing loss, and it's become the 3rd leading cause of years lived with disability, or YLD, and is a major concern for global health. We know that hearing aid users wait on average around 10 years before getting help for hearing loss, and during this time, communication with loved ones becomes more difficult, and they are become more isolated, and their health risks increased. We've done a huge amount of work and research recently into hearing loss and dementia. So unaddressed hearing loss was the most significant risk factor, being responsible for 9.1% of people developing dementia in a recent review by The Lancet in 2017. So in terms of a hearing impaired person walking into your department, how do we go about assessing them? How do we go about understanding their needs? So as always, everything starts with good history and a good look in the ears, and we'll cover otoscopy in a minute. I was also asked to go through tuning fork tests, which we'll touch on in a moment. Essentially, what you need to do is this a patient I can deal with, or is it someone I need to send to audiology, or perhaps refer on to ENT? So obviously, our direct referral guidance has been in place now for many, many years, and that will have all the information. I will send that with a pack with Bolo at the end. And I didn't want to lecture on you, just go through that route, but obviously all the bits and pieces are there. Um, We mostly take over 50s or previous hearing aid users, or those who have previously been reviewed by ENT. We obviously have a lot of community providers now. So if they've been given once over by ENT for their unusual conditions that would otherwise mean they couldn't come to audiology, then we're happy to take them on. The key thing is to look at exactly how long this hearing loss has been going on for. Obviously, sudden loss or sudden deterioration of hearing, and by sudden I mean within 72 hours here, unilateral or bilateral, should be sent straight to A&E for urgent or an urgent care ENT or clinic, preferably within 24 hours. And again, anything like an altered sensation or numbness in the face or observed facial droop would need prompt action. And again, persistent pain affecting either ear, which is intrusive or which is not resolved as a result of a kind of prescribed treatment. And as a general guideline, this includes pain in and around the ear lasting a week or more in recent months, probably need further investigation. Now, a history of discharge other than wax from either ear within the last 90 days, which is not resolved or responded to prescribed treatment, or which is recurrent, is much more of an ENT thing than an audiology thing. And again, just to touch on rapid loss or rapid deterioration of an existing hearing loss, and rapid being 90 days or less, needs an urgent referral but not an immediate referral. And obviously fluctuating hearing loss other than associated with colds, and tinnitus, which is kind of persistent, unilateral, pulsatile, or has changed in nature, would need further investigation from ENT. And obviously we can touch on vertigo, but with most balanced conditions, you need to do the basics and rule out such things as any cardiac involvement, but mostly this would need investigation by the ENT guys. When you do refer to audiology and you do come through the criteria, it's very helpful to include anything where previously investigated ear conditions, anything resolved, even if it's historic, always helps us because we normally come up in either the history or when we do our investigations. Anything with impaired vision or a patient with poor manual dexterity or learning disabilities is also helpful for us to know, as is memory problems or dementia or any neurological or psychological disorders which would impact on either communication or our ability to do hearing tests. And obviously people, you wouldn't know this, but a lot of people say are agoraphobic and they don't like going in our soundproof booths. Obviously, we will touch on the post-COVID changes in a little bit because obviously things have gone through a bit of a change recently. So here we have Dr. Hibbard investigating Bart's ears. I really hope you don't use this technique. It's really important that we have a good look around the ear canal, around the ear and at the eardrum itself. Do please use your small finger as a guard or hold the ear securely so people don't move away or towards you. And again, we do appreciate, but this is going to be a little bit more difficult if you're not doing so many face-to-face appointments or you're reducing the face-to-face appointments you offer. If you still have that patient, obviously you can take the history. We are here for you and we don't mind just kind of picking up the loose ends. If there is wax in the ears and you haven't been able to see the be able to see the ear because you're not doing the face-to-faces, we're not going to beat you up about it. We're going to try and do as much as we can to help the patient and your good selves at this time. What we are looking for, though, is a complete or partial obstruction of the external ear canal, and this is preventing full examination of the eardrum. So if we can't see the eardrum, we can't really see what's going on with it. So if there's any wax obscuring the view of the eardrum, ideally, GP surgery should arrange for the wax removal before making the referral to audiology, or actually refer to audiology service, but offers wax removal. And I will be touching on this interesting development in a little bit. Anything abnormal, the appearance of the outer ear and or the eardrum, and that includes inflammation of the external auditory canal, perforated eardrum, active discharge, eardrums either like retracted, or there's abnormal bony or skin growths, or there's swelling of the outer ear, or blood in the ear canal, or there's just something you don't like the look of, then that's over to the ENT. So I was asked to check on the tuning fork testing, which is still popular with GPs. I think we kind of stopped doing this around turn of the century or so, but it is a very, very useful way of kind of just testing a quick check to see if it's kind of which way the sounds are lateralizing, whether it's unilateral or bilateral, sensory neural or conductive hearing loss. There are, of course, limitations to the tuning fork test. You're only testing the one frequency, and you can get some false positive, but it is a good initial test just to kind of triage the patient. I'm often asked, how do we do this? Now, we don't do these tests anymore, but again, we learn these sort of things, and because we have all our rather fancier equipment here. But essentially, what you're doing with the Rhine test is you're kind of working out the difference between, is it kind of an air conduction issue or is it a bone conduction issue? And you're comparing the air conduction and the bone conduction sensitivity of the ears. And we do this by striking the fork. And again, this should be done on a soft surface, not a hard surface like a desk, where you get overtones and resonant issues. And we're alternating it between holding it at the entrance of the ear canal and or placing it firmly on the mastoid process behind the same ear. Now, and what we're doing, the sound will gradually dissipate. And what we're doing is seeing from one to the other, and we'll see which one lasts the longest. Now you get Rhine positive when the tuning fork is louder with the AC, the air conduction, so holding it outside the ear canal, and this is indicative of a sensory neural hearing loss. Rhine negative is where the tuning fork is louder on the actual mastoid bone, and this is indicative of conductive hearing loss, which does just help split the difference. The Weber test is really a test of lateralization, and therefore it can be used for patients who report a unilateral hearing loss. So again, striking the fork, be careful to do on a soft surface. The tuning fork is then placed midline on the patient's forehead, and we're looking to see where does the sound orientate. If the sound lateralizes to the ear with the hearing loss, it's normally a conductive hearing loss, as the improved bone conduction is due to the occlusion effect. If the sound lateralizes to the ear without the loss, then it's a sensory neural hearing loss, or perhaps a mixed hearing loss, as it's the best cochlea which is detecting the signal as the sound is passed through bone conduction through the mastoids. Now, if a patient hears it roughly in the center or in the midline, now this can be normal hearing, or it can be a sensory neural hearing loss, which is equal on both sides. Now, you may have heard of the whisper test. So the whisper test is finding just a little bit of increased traction in GP surgeries lately, and I can touch on this briefly as it might be something you'd want to do alongside or instead of. So essentially, the examiner is standing at arm's length, about 0.6 meters behind the seated patient, and whispers a combination of numbers and letters. So for example, 4K2, and he asks the patient to repeat the sequence. The examiner should quietly exhale before whispering to ensure a quiet voice as possible. Now, if the patient responds correctly, hearing is considered normal. If the patient responds incorrectly, the test is repeated using a different number and letter combination. Now, the patient is considered to have passed the screening test if they repeat at least 3 out of a possible 6 numbers or letters correctly. And the examiner always stands behind the patient to prevent any lip reading, and also be careful of any reflective surfaces. And each ear is tested individually. The way we do that is started with the ear of the better hearing, and during the testing, the non-test ear is masked by gently occluding the auditory canal with a finger and rubbing the tragus in a circular motion. The other ear is assessed similarly with a different combination of numbers and letters. And all this will just help you understand exactly what's going on with your patient. Now, just to bring up a few red flags, obviously asymmetrical, unilateral, fluctuating hearing loss needs kind of looking into. Sudden loss or rapid degeneration of existing hearing loss is also important to bear in mind. Now, pain with discharge that remains 3 days post-treatment, it just needs to start questioning exactly what's going on. as is persistent middle ear effusion in patients of Chinese or Southeast Asian origin. So hyperacusis, where people experience a heightened sensitivity to a particular sound that's not usually a problem for others, and this can be anything like fireworks, or it can be as something as banal as people tapping away on the keyboard, can be caused by the dehiscence of the superior semicircular canals, and that kind of needs looking into. As does the tinnitus if it's unilateral, pulsatile, or it's significantly changed in nature or is distressing to the patient. But generally, we have to bear in mind what may appear as a unilateral presbycusis could be a tumor, cholesteatoma, could be otosclerosis. A fluctuating hearing loss could be caused by Meniere's disease, and all of these need further investigation. Hearing loss and vertigo has many causes and needs investigation, as does hearing loss and tinnitus, especially for sudden onset, as you have to rule out an aneurysm, tumours, and so on and so forth. Now, I've been asked to talk a little bit about children, and again, just to say that I'm not the best person on this because we're an adult department, but I did have a quick chat with my PEDS colleagues just to make sure, but I was on the right tracks with this. So, signs of possible hearing impairment in children if they step into your clinic. You'll often hear reports of inattentiveness or poor concentration. They're not responding when their name is called or talking loudly. And again, do factor in very simple things that the kid may be at that point where they're ignoring their parents or talking loudly. You have to question, are there other siblings kind of competing for their attention? Listening to the television at high volume is often indicative, but sometimes people just like listening to TV loudly. Difficulty pinpointing where a sound is coming from is more indicative, as is the mispronouncing words or the speech delay. Do bear in mind, though, we see a lot of children who are multilingual now. I saw a patient on clinic last year, and they've been referred in because of concerns over delay in speech. And I sat with mum and the kid, and it turns out the mum was from kind of Central Europe. The dad was from Italy, I think, and the child actually spoke 7 languages, including 3 Central European languages fluently: Italian, Spanish, and French, completely fluently at the age of 6, but obviously had a little bit of a delay in English. Another big one is a change in behaviour or their progress at school. Just to update you on the NELF team, so this is the North East London Foundation Trust, who run the PEDS service. Now, the PEDS service is up and running, and they're doing their usual hearing assessments for the 0 to 19-year-olds. Hearing loss management, they're doing the microsuction clinics, hearing aid fittings, and hearing aid reviews, and they're doing the video consultant clinics. So the current wait times from NHSP are within 4 weeks, which is good, and new referrals are offered appointments very much under 18 weeks, but usually within 6 weeks. So when to refer to a child, parental concerns is the key thing here. Essentially, the team are happy to see any child with parental or professional concerns or those with any risk factors. Now, we'll only return those out of area referrals. They're better seen locally by another service, and they have a number of kind of e-referral online booking systems in place for the GPs. If you don't have access to them, they say that's fine, and they'll accept a letter or fill in an attached referral form. And again, I can send that with BOLA as well. And ideally, they need to know if a child has age-appropriate development or any known risk factors for hearing loss. And this is so they can be triaged into an age-appropriate clinic, because as you know, with children, there's many different ways of testing them depending on their age. So I'll just take a pause for a moment and just to see if there's any questions at this point. And if you type them over to BOLA, BOLA can summarize and ask. I would come off the sharing at the moment, but I think I had a little bit of an issue earlier, so I think we'll keep sharing the screen for the moment, if that's okay, BOLA.
That's fine. If anyone has any question, if you can kindly put it in the chat comment section, and I can send that off to Mark for you. I did put during the session, I did put a comment in the session saying, please, can you kindly, if you have any questions for Mark, if you can kindly put that in the comment box so I can collate that and send that to Mark. So if there's any questions, we'll wait for that another 2 to 3 minutes. If there is no question, then I'll just ask Mark to proceed with today's continue with today's webinar. So I don't know if anyone has any question. We'll just wait a little bit more. If there's no questions, then Mark will.
Can I ask Mark, please, if you don't mind?
Sure.
We do send some of the patients, we try to remove the wax as much as possible, but sometimes by the time they see you, for some reason, the wax is developed. So you've got the system, probably you can suck it out when we send you this patient to you rather than sending back to us.
Well, it's an interesting point you raised there because it is a perpetual issue. Just to reassure you that we're actually seeing patients within 15 days and have been since pretty much 24th of August when we reopened our services fully. I do appreciate there is a bit of a yo-yoing, and I was going to just explore the whole wax removal issue a little bit later on, but we can touch on it now as well. So we can remove wax here. We're fully trained and competent in doing so. And we've been doing a little bit of wax removal on our existing patients where hearing aids, the hearing aid users cannot use their hearing aids because the wax is present. We're currently in discussion with the CCG, and that's Dr. Jyoti Sood and other members of the clinical commissioning group around getting these wax referral pathways in place. They're very keen for us to do some wax. We're very keen for doing some wax removal as well. And we envision this will be tackled just very, very shortly in the next month or so. So watch this space. We are trying to do as best we can at the moment. We appreciate GPs can't always do a face-to-face or can't examine the ears. So at the moment, we are kind of on an ad hoc basis removing wax from our direct referrals. But that's like not the official line at the moment. It's just as an interim measure until we get these pathways and payments confirmed with the CCG. And then what I'm eventually looking to do in the near future is we will remove wax from our patients referred to us, our existing patients. And alongside this, we'll actually have a direct referral or direct access pathway for you to refer wax directly to us. So we'll take the wax out for you. But I do appreciate it's very frustrating having patients yo-yoing around, which is why I've been pushing this so hard to get the wax removal here set up.
Thank you.
Okay, so fully take that on board, and it is definitely something we are working towards here. Unfortunately, our December meeting got postponed due to just tackling COVID, and the January meeting was meant to have this week. And again, with the vaccinations being rolled out, that in turn got postponed. But it's high on the agenda. It's literally let's sign this off, agree the pathways, and it's done mode. And then that will be fantastic. And then you don't have to worry about doing the wax removal. Syringing was being practically outlawed by NICE back in 2006. And we have all the training, all the equipment and the expertise here to take the wax out using microsuction, which, as you may know, is the clinical gold standard for taking wax out of ears. And we are raring to go on this. So as soon as we can do it, as soon as we get the nod, we'll be setting that up, and you'll be seeing that appear as an option. And we'll be sending out some advertising via the CCGs on that as well, as and when that's a thing.
Okay. Do anyone have any other question for Mark before he continues with the second session? No. Okay, Mark, over to you, please.
Thank you, Bola. So I've been asked to talk a little bit about hearing test results. Tim's did come up, but was probably a good point to just review our kind of hearing test results with our PTAs as well, our pure tone audiograms. So rest assured, we don't test 3 people at the one point. That would really, really help my waiting lists. We have a couple of conductive types of hearing loss. Sensory neural can be mixed or central. They affect different parts. The conductive hearing loss is obviously a result of dysfunction in the middle or outer ear. So this is where the bone conduction is a little bit different to the air conduction when you do your tuning fork tests. The sensory neural hearing loss is a result of cochlear damage, so it's kind of sensory, and or the neural eighth nerve here. So the bone conduction will be about the same as the air conduction. And the mixed hearing loss is a combination of dysfunction of the middle and outer ear and the cochlea or the eighth nerve, and it's a certain amount of AC and BC loss. Central hearing loss, sometimes referred to as retrocochlear hearing loss, refers to everything in the auditory cortex of the brain, whereas the peripheral hearing loss is a result of everything before the brain, the outer, middle, and inner ears. Now, obviously, when we describe hearing loss, we use a kind of a table roughly split up into degrees of severity. Normal hearing is anything concerned up to about 20 dB. The mild hearing loss, where people are just starting to miss things in kind of larger groups or meetings at the table, is kind of extends us up to about 40. And then we're looking at moderate hearing loss, where normal conversation just becomes that much more difficult. TV becomes a lot more difficult. And severe hearing loss and profound, this is where things get very, very difficult for our patients to play an active role in their environment and their family. So just to make a note that the degree does not necessarily predict the disability. We can have people with quite moderate to severe hearing loss. And I saw a gentleman the other day, he's quite happy. When he used to go to the pub, he'd meet up with his friends. They'd meet about 2:30 after the afternoon rush. They'd talk quite loudly. He goes at home, he lives alone, so he has the TV up as loud as he likes. And again, it doesn't impact him too much. Equally, we see people like ourselves, very busy at work, doing meetings, doing Zoom meetings. They only have a mild hearing loss, but their impact on their life and their lifestyle, their job and their family environment is much more pronounced. So you may be familiar with the symbols we use in pure tone audiometry. Obviously we have the right and left, bone conduction as well. We have the little brackets for the mask thresholds. Sometimes you'll see these colored in, half colored in, and that's when we've got just to show what we're actually masking. Now, I'm not going to go into masking at the moment because I think that's another lecture entirely. I thought what would be useful is if I actually just showed you a few audiograms from my actual patients I've had recently. We kind of have all these textbook ones, but you very rarely see a textbook patient. So these are kind of grabbed from various patients I've seen recently. The format's going to change as I've kind of recorded them on different machines. So this is your very typical bilateral kind of sensory neural hearing loss. This is typical kind of mid-70s patient who will attend to your clinics. What it does show though is that patients love having a kind of percentage. I'm 70% deaf, I'm 40% deaf in my left ear, but really we don't like to describe it that way, hence doing the mild, moderate and severe. Much the same way I wear contact lenses and I'm not 16.8% blind in my left eye, etc. But what's interesting we see here is that this patient actually has normal hearing in the very low frequencies, going all the way touching onto the profound loss in high frequencies. Now, sometimes this is caused by kind of noise exposure, and sometimes it's just general wear and tear. But what is important is that we have a massive, it's not just a diagnostic aspect to our jobs, we have a really important counseling kind of role to our jobs and helping patients to understand their hearing loss, its impact and its effects on the environment and the way they move around. It might be, but they haven't heard certain sounds for many, many, many years. And often, as we know, patients do take around 10 years before they present to our clinic. A patient I saw a couple of weeks back, this one had a perforation in the right ear, and what we can see is a drop in the low and mid frequencies, and you will see the dotted line with the brackets in red, and that's your underlying bone conduction. So when we test the bone conduction, the underlying hearing is fine, but due to the perforation and the inefficiency in getting that sound into the system, that's why we have the typical drop in the low and mid frequencies. This patient I didn't see myself, one of my students saw this one, but the They had bilateral wax, and normally we'd obviously do what we can, but normally they get sent back for wax removal. I thought it would be interesting to students just to see and test this patient as part of their learning. And what we see here is a conductive loss. So there's a big gap here between the air conduction thresholds, the bone conduction thresholds. Another interesting feature of this is that the bone conduction came out exactly the same on every frequency on both sides. But it does show here again, but there's good underlying hearing, but due to the wax, the obstruction there, we have a conductive element to the hearing loss, and this patient was indeed really struggling with telephones and so on and so forth. And keeping things topical, we saw this patient just yesterday evening. Now, quite interesting, you'll see there is a kind of shadow curve. Normally we'd see that a little bit further up the chart. And this is where, when we play the sounds on the left and the blue here on the blue side, what we'd expect is that the cochlea in the right ear would actually pick this sound up around the 50 to 60 dB mark, because there's only a few 40 decibels or so attenuation in the head as a physical object. And here we see them lurking around the 90 to 100 mark. Now this is quite interesting. It also means that when we mask the ear, so we mask the right ear to counteract effect the sound being picked up by the right ear, the air conduction thresholds did indeed drop, but it did indeed drop off the charts here, which again, very interesting feature of a 19-year-old young lady who apparently had an ear pod explode in her ear. Now she is looking to take this through the courts. She did say she had a gradual reduction. But the other thing to note here is that she did have O2 acoustic emissions present in her left ear, which would indicate that she has outer hair cell function of at least 30 dB or better. So every audiogram has to be taken with a pinch of salt. And this one didn't come out just quite as well as I'd like, but just to give you an indication, but this again is not an unusual hearing loss. It's quite typical of a slightly older patient who spent some time working in a very noisy environment. This is a local lad who was working in the Ford factory for many years, pressing steel panels. You might just be able to see there on the share. We kind of superimposed some bits and pieces in terms of everyday normal sounds. I think somewhere in the formatting, these have got a little bit smaller than usual, but you might well be able to see the pneumatic drill around the 85 dB mark as a marker. And it's always interesting to note that 85 dB by law, if you're in an environment where that is 85 dB or louder, you have to wear hearing protection by law in order to be working in that environment. And with this patient, it's literally the quietest sound they can hear. And again, this is a patient seen for the first time. And again, you do wonder how on earth they managed to just get by life with this type of hearing loss. But again, it just goes to indicate that patients do occasionally wait 10 years or more of understanding they have a hearing loss. Sorry, my printer's just mysteriously started up in the background. Apologies. Really showed up significant difficulty in the questionnaires we do. The questionnaires we kind of explore the impact on their life, their lifestyle, their ability to communicate. If there's have any problems with the telephone, the television, speech one-to-one, crowds, that sort of thing. Now, this patient was actually really worried about the stigma attached to hearing aids and hearing loss, because he remembered his aunt had an old style hearing loss from the 1950s. The hearing aids then, of course, were body-worn ones with very thick cords and weren't very effective. Technology, I can assure you, has moved on somewhat since then. Now, we were asked to look and talk over to the pressure test, the tympanograms here. And again, I've tried to pick a textbook one here just to go through the three types. Now, as the Jackson 5 put it, it's easy as ABC. There's three types of A's, which are all centered around the zero pressure. We are, of course, looking at the function and movement of the eardrum and the middle ear system here. So we see the high compliance is recorded as an AD, low compliance as an AS, flat traces as a B, and negative compliance as a kind of a type C. So type C is very typical in glue ear. The flat trace is where we've got huge amounts of effusion or infection kind of parked up against the eardrum, which is preventing it from moving at all. And of course, the high compliance is often we can either have someone who's had surgery on their ears and the eardrum's a little bit floppier, it's hypermobile, or we can perhaps have some ossicular discontinuity. So again, I thought instead of some textbooks, I thought I'd bring you some actual real life ones. I tried to capture this. It's a little bit fuzzy on the text just so we can try and share the screen and make it as easy to see as possible. Now, I don't know how involved you all wanted to get in with this one, but what we can see here is we've got good movement of the eardrum. That's fine. We've got normal ear canal volume. We have normal middle ear mobility and slightly negative middle ear pressure. Now, I would throw this open to you, but perhaps if we're shying away a little bit, what we'll tell you is this is perfectly normal if you're a child. It's minus 145 dAPA, perfectly normal for a child. This is, of course, abnormal for an adult and is kind of indicative of partially blocked eustachian tubes. Now, this one again, very low compliance, very restricted mobility, kind of normalish middle ear pressure itself, but borderline or wide growth rate, which means the actual base of the peak there is very wide. And again, what we're looking at here is glue ear, typically, just clogging up the eardrum, not allowing it to move. Otosclerosis, where the bones have stiffened up, the ossicular chain is not allowing the sound to permit through. Or we've got a severely scarred tympanic membrane, or there could be a plaque over the tympanic membrane, and we typically see this with wax as well, where patients have pushed the wax all the way down their ears and stuck it onto their eardrum. This next example is a type AD curve, and we're looking again at kind of normalish ear canal volume there, but we have an extremely hyperflaccid middle ear, but normal middle ear pressure. Narrow growth rate, it's a boom up and down on the peak there, and what this is caused by can be an ossicular disarticulation. Always interesting in the history to see if they've had a road traffic accident, and a more detailed testing is indeed indicated on this occasion. And another example here for you, massive ear canal volume. You'll see there it's at 3.5 centimeters for the ear canal. No mobility at all, no middle ear pressure caused, no growth rate. So we're looking here at an open perforation, or it could be a patient with patent pressure equalization tubes, PE tubes, or grommets. So that could be perfectly normal, or could be cause for concern, depending on how the history of the patient. So again, I didn't know if it was worth pausing here just to see if there's any questions about the hearing test interpretation or TIMPs. And I'll just throw that over to you, Bola.
Again, if anyone has any questions they would like to ask Mark, please feel free. You can either put it in the comments chat section box, or you can actually unmute yourself and ask Mark a question. So I'll wait for about another 2 to 3 minutes to find out if anyone has got any questions about what they've heard so far, or they need clarity on certain things. This would be a good opportunity for you to ask Mark any questions so far based on what you've heard, or based on things you might need further information or clarity on.
And again, if something occurs to you a little bit later, I'll give you my contact details on the screen, and you're very welcome to get in contact with me if you have any questions that occur to you a bit later on after this is finished.
Okay, I've not had any question in the comments in the chat.
We can always pick it up at the end, I guess,
if
if anything comes up.
Questions, please feel free to just put it in the chat session, and I'll collate that, and I'll send that to Mark, and he'll be able to kind of answer any questions you might have. So please feel free to put your comments or anything you probably want to ask in the chat box section as well. Thank you.
And thank you, Bola. I was asked to go through a few case studies and kind of picked out 3, just interesting ones, just to go over with you. First case study, 53-year-old white male. He's a smoker. He complains of reduced hearing in the right ear for a couple of weeks. He's not too bothered, but he's attended an appointment as he kept getting nagged by his wife. What is a likely diagnosis? And again, I would, if this is a little bit more of an interactive situation, be able to just throw this out to you, but just to go through with you. But often, sometimes, the easiest things is what it is. Sometimes it's the a simple thing. It's a simple conductive issue like a wax or an upper respiratory tract infection causing middle ear effusion or an ear infection even. So the key here is history and examination. And if earwax is present, but remove it, but do make sure you recheck, but this is resolved. Tuning forks can, of course, reveal any sensorineural hearing loss. But the most important thing here is time frames. They're most important. Recently reduced with no obviously benign cause, needs rapid assessment by ENT. Going back to those red flags we went over before, the sudden sensorineural hearing loss needs rapid steroid treatment, preferably within 30 days of onset, and that's to reduce the morbidity. This is a challenge. Often patients will wait a week or so, and again, at the moment, with the pressure on appointments, it can take a few days to come through, and then you've got to get them over to us in ENT and assessed. So 30 days is a little bit of a target at the moment. Obviously, a unilateral loss with associated facial droop needs rapid assessment by ENT and or follow the stroke pathways if this is what you suspect. So our second case study, this is a 62-year-old female from Kowloon. She's got left-sided issues for a few months now. Fit and healthy, she does Zumba quite regularly, no recent ERT, and otoscopy is completely normal in the right, but has effusion on the left-hand side. And again, what should you do? I'll just show you a picture of the kind of effusion there. You can see lots of liquid building up on the behind the eardrum, just on the one side. Now, it sounds dramatic, but you really need to consider an urgent 2-week wait referral to ENT. There is indication that it's nasopharyngeal carcinoma. There's a 3% predictive value in Chinese or Southeast Asian population. And especially if it's effusion, it's not associated with an URTI, or doesn't it resolve once the URTI is passed? Now, apparently I was reading a journal in the Chinese Journal of Cancer from 2011. Cantonese men who inhabit the cities and countries in Pearl River Delta and the West Pearl River Valley actually have an incidence of 30 in 100,000, and it's not much better for women. So that is just something to bear in mind. Case study 3. We have a 52-year-old female patient who returns to your surgery.
The second case you showed us, can't it be the eustachian tube dysfunction on one side rather than the, malignancy I've never seen in my life for so many years?
It's true. Do excuse me for perhaps picking a more obscure one, but it is something that comes up. I chose this one because we've had actually have a few through on ENT recently. And what we actually see is because of the nasopharyngeal carcinoma, it does present with this this effusion, and everything else is perfectly normal. History is perfectly normal. Nothing else pops up. It's just this effusion on the normally on the unilateral, and it does something but pops up every now and again.
Thank you.
Case study 3. So a 52-year-old female patient returns to your surgery 4 days after you gave them treatment for otitis externa. They're now in more pain than before, and the patient has a history of lymphoma and has recently finished chemotherapy. What do you do next? And again, the important thing here is to rule out necrotizing otitis externa. It sounds a bit severe, but we are seeing in the last 2 years I've been at this trust, we've seen probably about 7 or 8 of these cases now. Immunocompromised patients with otitis externa are at increased risk of developing necrotizing otitis externa. We also see it on immunocompromised patients on the ward, and often these aren't picked up immediately, and it is very, very dangerous. It spreads towards the skull base, can affect the nerves, and it can be fatal. And again, if a patient has not responded to treatment, even for something as just run of the mill as otitis externa, within 72 hours, do consider an urgent referral to ENT. So I think we had a few questions there. Hopefully we managed to touch on there. More, it was just a few examples just to give you just to kind of challenge your thinking. Often we have a lot of normal patients. 95% of them are going to be just your run-of-the-mill bread and butter patients. But we do occasionally have these interesting patients we just have to be aware of. Again, Bola, if we can, I'm happy to take any questions. It was a little bit of a quick one this time, but just in case there's any questions about other presentation or other patients or about the cases we discussed.
Okay, thank you very much, Mark. I don't know if anyone has any questions that they would like to ask.
Thank you.
Yeah, Nancy, do you want to ask any questions? No. Okay, if anyone have any question, they can unmute themselves and ask the question, or they can actually put it in the chat comment section, section, and I can put that to Mark as well. So we'll wait another 2 to 3 minutes to see if anyone has got any questions. But if you haven't got any question, that's also okay. We can finish a bit early. But if you have questions, please let me know. You can put it in the chat section, or you can actually unmute yourself and ask Mark the questions as well. A copy of this PowerPoint presentation will be sent to you, and I will also get Mark to send me a copy of the referral letter, which you can use to do referral to ENT. That will be attached to the email I sent out today, so that you can actually have the referral form and a copy of today's PowerPoint presentation. The recording of this webinar will be on our website as well for those who want to go back and have who are unable to attend today's session. It will be made available to them as well. I don't know if anyone has any questions. If there's no other questions, we would just want to say thank you, Mark, for today's session.
I've got a little bit more to go, Bola.
Okay. Okay.
I know I haven't had any lunch yet myself. I was going, oh, quick, let's just end it there. I should have done one. Let's just wanted to touch very briefly on accessibility and just reflect on how patient friendly is my practice for patients with hearing loss. I'd just like you to consider ways in which your practice can be accessed by hearing impaired patients, and these can form part of a quality improvement initiative. We can start with deaf awareness training, of course, and it's just how they access appointments via either monitored email or text phones, and just make sure that's open and accessible. Alert screens in GP surgeries. Sometimes if they do have a PA system, they can't always hear what's going on. So nice flashy screens we're seeing more and more now, which is great. And old is gold. T-loops still work quite well with our hearing aid patients. And another thing just to touch on is, have you ever considered a hearing assessment for our cognitively impaired patients or our learning disability patients? Please do bear in mind that, touching on earlier about the incidence of hearing and dementia and the links that were being shown there, it is important that we do have any patients with cognitive impairment will be assessed. And I just wanted to very quickly update you on what we're doing as an audiology department. We had a bit of feedback from Dr. Jyoti Sood about setting up an ERS advice and guidance for audiology. Now, I'm very happy to facilitate this. If you feel the advice and guidance would be useful for you, especially the challenges we're facing with doing remote care, then we're more than happy to set that up. Please leave a yay or nay in the comments, or email me about it afterwards, and I'd be happy to set that up. I am looking at setting up some community ear care clinics where we will visit some of maybe the bigger polyclinics, and we'd be happy to look at your patients, do an initial kind of hearing screening, check for wax, and work out if they're best referred to audiology, audiology for assessment, audiology for wax removal, or the ENT. And as we touched on earlier on in this presentation, I am looking at setting up a direct referral for earwax removal here at Queen's and King George site. But again, just to stress, that's not a here and now, but coming up soon. We just need to clear the final few hurdles with the CCGs and get things rolling. And we're looking at expanding our balanced assessment clinics as well, so you'll have somewhere to send your dizzy patients. But these are, as I mentioned, just in discussion with the CCGs, and you know, we're moving that forward just as soon as we can once we've surmounted these other challenges that are currently presenting. Quick bit on the references as well. I didn't quite get around to copying and pasting all the ones I've used, but special thanks for Dr. Davina Maru, who is your RCGP kind of representative for ENT and audiology. And just to leave my contact details there, any referrals, any general questions, please send through to my admin team. Anything else about the service itself, or anything specific about patients, please send through to my email there. I'm happy for you to contact me. I'd just like to thank, obviously, Bola and Paul from CEPN for inviting me to talk today, my various colleagues who helped give this a little look over for me, and to all of you for taking the time out to listen today and for carrying on doing what you're doing. And just keep up the good work, guys.
Thank you, Mark. Again, the presentation. Oh yeah, I'll get some comments here, and it says, "Many thanks, excellent." That is one of the feedback we had, Mark.
Oh,
so thank you for taking your time out. I know you were very, very busy, you know, doing clinical.
Just a bit. We had more than 3 people isolating with various bits and pieces. Just guys to mention that I will be sending Bola a full pack for ENT, the PEDS team, and my service as well. And we'll put a few bits of like an information pack together with this presentation, so you have it all to hand.
Okay, thank you very much, Mark. Do anyone have any questions they would like to ask Mark before we wrap up? We still have 5 more minutes to go. So if anyone has any questions they would like to ask Mark, please feel free to put it in the chat box. If not, you can always drop Mark an email as well if you've got questions as well. And we'll make all this presentation and any resource materials available to you by the end of the week, which is tomorrow. So we'll endeavor to get that to you. So if we don't have any questions for Mark, all I just want to say is thank you, Mark, for facilitating today's session. And thank you everyone for taking part and contributing to today's workshop. Thank you very much, everyone. Thanks.
Excellent. Thank you very much, everyone. Bye for now.
Thank you. Bye.
Thank you. The violence escalates.